So let me go ahead and give a brief introduction to our next featured speaker in the educational track. Ezinne Chinemere is the founder and CEO of Kezi Health LLC, which provides program and project management services to organizations within the public health sector. And you can read a little bit more about Kezi in the event pamphlet. Notably, Ezinne also has 10 years of experience managing public health and social service programs and initiatives, including and beyond asthma and related areas of health, such as lead poisoning and diabetes, and also sexual violence. And you can read a little bit more about Ezinne's background in the pamphlet, which is accessible from the main event website. And for those of you who are just coming in for the afternoon, please also watch the event chat for announcements throughout the day, including detailed information about how to make sure you get all your documentation prepared properly to get your continuing education credits. All right, Ezinne, the floor is yours.
All right. Hello, everyone. Good afternoon. I really hope all is well with you and everyone, and you're enjoying the summit. I am extremely grateful to be here today. Thank you for the introduction. My name is Ezinne Chinemere. I am the founder and CEO of Kezi Health LLC, which we provide training and public health consulting for health education, health educators and community health workers for home visiting, engaging with families, chronic disease management. I'm located here in Baltimore, Maryland, home of the Baltimore Ravens. And I'm also the manager of the strategy and planning with the Baltimore City Department of Social Services. And I also have the pleasure of being on the board of the Association of Asthma Educators. And so I'm super excited to be here and talk about a topic that I'm really passionate about. And it's a topic that I'm sure all of you are familiar with because you've done multiple trainings and programs when it comes to addressing health disparities. But I'm hoping I get an opportunity today to be able to kind of shed when it comes to addressing health disparities in a different light and looking at systemic racism and its impact on health. Now, the objective for today, during this session, we will discuss and address systemic racism and its impact on health outcomes of those within the Black and Brown communities. In my presentation, you are going to see Black and Brown communities and people of color used interchangeably. That is not always the same group of people, but just for the sake, we're going to use them as the same group for this presentation. We will also look at how systemic racism fuels health disparities, particularly among our asthmatic population. And by the end of this session, you'll be able to, one, define systemic racism, gain a deeper understanding on how systemic racism impacts health outcomes for our families within the Black and Brown communities, again, particularly with our asthmatic families. And we want you all to consider how we interact with our families to foster a positive experience among the Black and Brown communities, and kind of how can you play a part in being able to address health disparities, particularly around systemic racism. So what is racism? Let's just start with a basic definition. The American Public Health Association's past president, Dr. Kamara Phyllis Jones, defined racism as a system of structuring opportunity and assigning value based on the social interpretation of how one looks that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. I love this stuff. I think it's one of the best definitions of racism. I love it so much because of two parts. One, she states that the system of structuring opportunity and assigning value based on a person's color of their skin, the ability for a group of people to create opportunity for themselves and not for others, as well as determine the value of a group of people based on something that's completely subjective in regards to assumptions, really signifies how problematic racism is. But she also talks about how racism saps the strength of society and wastes human resources. The society is only as strong as its weakest link. And racism prevents individuals from the ability to living, working, and thriving at their maximum potential. So Dr. Jones's definition was so amazing and in-depth, but what does all of that mean in layman terms? Racism is treating people unfairly just because of the color of their skin. Racism has regulation of Black and brown people to an inferior status, and that's how we get white supremacy, where they believe as a person of the white race, they are inferior or they are superior to a group, and that group would be to the Black and brown community. Racism is not always conscious, it's not always explicit, and it's not openly visible all the time. And racism can take many forms and can be embedded in many or all aspects within the lives of Black and brown people. And racism is a public health issue. There's no doubt about it. Racism is a public health issue. It damages the health of society overall. And yes, that does include the health of white people. So in this slide, we have another working definition at the top where it says racism is the individual and systemic manifestation of the uneven distribution of power and prejudice related to cultural defined ideas of race. There are many different types of and aspects of racism. If you Google racism, you'll find a lot of more modern definitions to certain different aspects of racism. But the four most common types of racism you may know is structural, institutional, interpersonal, and internalized racism. Now, your internalized racism and your interpersonal racism is more on the individual level, while your institutional and your structural racism is the systemic portion or the systemic level. So what is systemic racism? Simply, to be as simple as possible, let's just say systemic racism is institutional and structural racism combined. Now, if you go on Google, you'll be able to find multiple different definitions for systemic racism, but for the purposes of this presentation, we're just gonna say institutional and structural racism that was defined in the previous slide combined makes systemic racism. Systemic racism is the widespread and deeply embedded in systems, laws, written and unwritten policies, and entrenched practices and beliefs that produce, condone, and perpetuate the unfair treatment and oppression of people of color. Again, racism is often invisible or seen as the norm within system or systems that it does not directly impact, and does come with adverse health consequences. The iceberg. I know many of you are familiar with the iceberg illustration. It's been used multiple times to describe multiple different things, but it can be used for systemic racism as well. For most people who do not identify themselves as Black or brown, the visible part, the top part of the iceberg that we see, is usually the more overtly obvious racist acts, like calling a Black person the N-word, or verbally expressing your dislike to work with non-whites, or referring to all Hispanics as Mexican. But the base of the iceberg, which is the biggest part, is where systemic racism lies. The base exposes people of color to health-harming conditions, imposes barriers, and strips them from the opportunity to improve their health. And for many, it keeps them in poverty. And if you look at the factors down there with the systemic racism, they look pretty similar to the social determinants of health. So there's definitely a correlation there. So let me give you some examples of systemic racism. Now, we have residential segregation, unfair lending practices, and barriers to home ownership. And it's not just the fact that it's a barrier to home ownership, it prevents Black and brown people from the ability to accumulate wealth and be able to pass that wealth from generations on in. Environmental injustice, air pollution, exposure to lead, unclean water, bias policing and sentencing of Black and Hispanic men and women, voter suppression, and exclusionary zoning laws and redlining. Now, for those who may not know, redlining is a discriminatory practice in which services, both financial and otherwise, are withheld from potential customers who reside in neighborhoods that are classified as hazardous to invest. These neighborhoods have significant number of minorities in it, typically Black and brown communities, and can be low-income residents as well. And exclusionary zoning, those are laws placed that place restrictions on types of homes that can be built in particular neighborhoods. So common examples include like minimum lot size requirements, minimum square footage requirements, prohibiting multifamily homes, limiting the heights of buildings. Exclusionary zoning contributes to the racial wealth gap. And if Black families are excluded from higher priced neighborhoods, or if neighborhoods where Black families live are zoned into being less valuable, the homes purchased by the Black families are not worth as much over time to those compared to those who white families that live in other neighborhoods. And in the long run, not only does it diminish the wealth of the individual or the family who purchased the home, it diminishes the wealth for the people who will inherit the home as well. So systemic racism and health, decades, even generations may pass between the exposure to systemic racism and the evidence of the health damages. So this image on your screen, I pulled it from an article written by Braverman and colleagues on systemic racism and structural racism. The appendix shows in a simplified form a series of sequential general steps represented by boxes through which systemic racism is thought to produce racial disparities in health. It lists examples of factors often involved in each step. Although some of the factors could be listed in more than one step, the authors avoided that just for the sake of readability. Also not displayed are the many potential interactions among the listed factors, or between the listed factors and the unlisted factors that can aggregate the health damages, or could aggravate the health damages. And the authors also stated that most people of color are affected by multiple factors and pathways. So it's not, nothing works in silos, of course. But these are 4 causal pathways that are examples of how systemic racism can damage health. So if you look at the first box, it says systemic racism. And in that box, you see many of the examples I had already provided. So racial residential segregation, voter suppression, bias policing and sentencing, white supremacy. These are all different factors within the systemic racism box. And now these different types of, or examples of systemic racism then prevent the access to resources and opportunities. And some of those factors can include economic disadvantages like lack of access to wealth, home ownership, and education opportunities, disenfranchisement, and mass incarceration. Also, these factors can then cause health harming or lack of health promoting experiences. So a lack of access to wealth and home ownership, mass incarceration, they in turn can cause issues like chronic stress, environmental hazards, both inside the home and outside of the home, inadequate housing, exposure to violence, and inadequate medical care. And we all know that these health harming experiences or the lack of health promoting experiences do have biological effects, can cause inflammation, immune system dysfunction, infections, premature aging, and all of the biological things that are occurring then worsen the health among people of color, which cause health inequities, which we like to also call health disparities. There we go. So what is a health disparity? We talk about it a lot, especially amongst the asthma community. What health disparities are very visible, but what are they? So health disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. Health disparities are directly related to the historical and current unequal distribution of social, political, economic, and environmental resources. And what do you think is the major causes of historical and current unequal distribution of resources? You guessed it right, systemic racism. So let's have an honest conversation about health and health disparities. What's the truth? Black people are sicker and dying earlier than our white counterparts. Even educated Black people are sicker and dying younger than their educated white peers. Approximately 40 million people identified as non-Hispanic Black in the United States in 2019. That made up about 13% of the population. The US Hispanic population reached a record of 60.6 million people in 2019, and that was up 930,000 people over the previous year, and that makes up about 18% of the population. According to the Census Bureau projection, the 2020 life expectancy at birth for Black people was at 79 years of age for women and 74 years for men. For non-Hispanic whites, it's projected at 82 years for women and 78 for men. That's a drastic difference. And as you can see from my slide, the death rates in most chronic diseases, cancer, high blood pressure, asthma, et cetera, is higher for Black people than white. And this is a real concern because as we look at this, especially as health professionals, we say, how do we close this gap? Because it is sucking the resources, the ability to have long years, long working years, long years with our families in the United States. So this is a huge problem. So racial and ethnic disparities in asthma have been around and been documented for over years, and multiple factors are linked to the cause. We have decades of research and data that confirms that Black and brown people are disproportionately impacted by asthma. We know this. We do not need any more research to explain to us that these disparities exist. We all know, everyone here, we know they exist. But now it's time for us to focus on understanding the problem by identifying the root causes and finding solutions to close the disparity gap. But for those who maybe this is their first time in the asthma space, or maybe this is their first conference, I do want to be able to put out some of the asthma disparities over the recent years. So in 2017, non-Hispanic Black children were 5 times more likely to be admitted to the hospital for asthma as compared to non-white children. In 2018, 2.7 million non-Hispanic Blacks reported that they currently have asthma. Non-Hispanic African Americans were 40% more likely to have asthma than non-Hispanic whites. And in 2019, non-Hispanic Blacks were almost 3 times more likely to die from asthma-related causes than non-Hispanic whites. And non-Hispanic Black children had a death rate 8 times that of non-Hispanic white children. So I'm sure that you've all seen this slide before. These are the determinants of health: social economic factors, physical environment, health behaviors, and healthcare. It breaks down the percentage that each factor contributes to our overall health. And we all know that most factors that contribute to our health live outside of the doctor's office. But for Black and brown people and families, each of these factors can be impacted by systemic racism. We know our health behaviors can be a result of the stress we encounter on a regular basis. But for Black and brown people, there's an added stress to maneuvering through an oppressive system or systems that is embedded with prejudice, bias, and discriminatory practices. But I do want to take a second to kind of focus on the social determinants of health. As public health providers, we're very familiar with the social determinants of health and its categories: economic stability, neighborhood and physical environment, education, food, community and social context, healthcare systems. We're very, very familiar with the social determinants of health. And these days, it is pretty rare to find an asthma program that does not attempt to address at least one of the factors within the social determinants of health. Usually we use these factors in our programs to help us identify and eliminate asthma triggers, understand the lack of medication compliance, understand and address transportation needs for those who continue to miss doctor's appointments or appointments with specialists. But let us look at the social determinants with a systemic racism lens. So let's talk about the disenfranchisement of people, which is depriving them of the right to vote or decreasing the weight of their vote. Despite legal emancipation, voter suppression continues to deprive people of political power today. Even as recent as last year, there were many headlines in the news regarding voter suppression in the South. And as an FYI, almost 60% of the Black population live in the South. So the lack of political power produces a lack of access to key resources and opportunities needed to be healthy, such as clean water, pollution-free environments, well-resourced schools, affordable housing, and access to medical care. When people are prevented from voting or when their votes count less, they can't get elected representatives to act on their behalf. And the impact of voter suppression is not one that's only related to the Black community. We have heard a lot about the attempts of voter suppression within the Hispanic population in the South, especially during the last presidential election. So what now? You've learned all this information about systemic racism, how it causes health disparities, and how it impacts the health of our families, especially our asthmatic families. So what do we do now? What's next? We need to address the root problems with the systems in order to be able to see the greatest impact. And for some solutions, we will see an immediate impact, but for most, it'll take generations. We're not going to see it in our lifetime, but the work starts now. Advocacy is a driving force to making sure anti-discriminatory laws and policies are enforced, and new legislation that promotes healthy living for all people are passed. Advocacy also starts at home. You know, we didn't talk a lot about individual racism when we talked about interpersonal or internalized racism. So stuff like more on the individual level, but we have to be able to check our attitudes, being able to be aware of biases and harmful practices. These things are a great start. Sometimes being in the workplace and checking those who may have some views of people of color that they may not believe impacts their ability to practice, but it does. At the end of the day, the goal is justice. And I know you've all seen this slide before. Dr. Jones uses this slide a lot as well in her presentations, but I love it because it really shows you what the definition of each in a visual sense, so that you understand why justice is the end goal. So when we say, when we talk about inequity, we see on one side of the tree, there's a lot of apples and they're falling greatly. But on the other side, there's only a few apples. And the little child is wondering when the apple is gonna fall. And so we know that this shows that there's a lack of resources on one side of the tree versus the other side of the tree. And then when we look at equity or let's go to equality. Equality would be the even distribution of tools and assistance, where now both kids have the ability to use a ladder to equally access the tree. But there's still more apples on one side of the tree than another side. So even though myself and a white counterpart both have an equal platform to be able to get to the tree, I don't have as many apples on my side of the tree. So now we're going to talk about equity. Now, it's custom tools that can identify and address inequality. And we see that on one side of the tree, they have a ladder that is shorter than the other side of the tree. So now, let's say I'm the person on the right side of the tree, I have a taller ladder. So I can pick the apples a lot easier than my colleague who's on the other side that has a shorter ladder. But I still have the least amount of apples on my side of the tree. So I'm only picking 3 apples with my taller ladder, although my colleague is picking 9 apples on a shorter ladder. And maybe they're waiting for the apples to fall while I can just pick them right out. But once my 3 apples are done, they're done. While they have a plethora of apples. So when they're done with their 9, they can still come back and get more. But justice, which is where we're trying to get to, as the fixing of the system to offer equal access to both the tools and the opportunity. So sometimes I might need a taller ladder to be able to get to the tree, but we both have the same amount of apples on both sides of the tree. Sometimes I actually may need a ladder and something to pick it with, but we both have the same amount of apples on each side of the tree. And that's the main goal. That's where we're going to get to. It's not going to happen overnight. It's going to take years. It took years for us to get there. I remember at one point in time, even slavery was backed by laws. And that was 250 years. And then another 100 years of fighting for equal rights and being able to have the right to vote, be able to go to school with individuals who didn't look like myself. And now we're here looking at the health impacts that systemic racism has caused biologically over the years, but we're still facing some of those issues in the systems today. So, it really does boil down to advocacy. And the only way we can do it is together. It's not a Black issue, it's not a white issue, it's a together issue. It's not a Hispanic issue and a white issue, it's a together issue. The health of me impacts the health of you. And the only way we can do that is by seeing each other as equal. So these are my references. And I just thank you so much for the opportunity to talk to you today. I hope that you learned something new. I'm gonna put a little shameless plug. If you have the ability to, this August, the Association of Asthma Educators will be having their annual conference in Chattanooga, Tennessee. I'll be speaking there with 2 other of my colleagues, and we'll still be talking about health disparities within minority populations, and I would love to see you there.
Great, Ezinne, thank you so much. And the AAE conference is terrific. So for those of you who are able to make the time to participate in that, it's a great learning opportunity. We have some time for questions before we go into the exhibitor meet and greet session. And I also, Ezinne, if you are willing, it would be great if you could share your PowerPoint file for your slides so that we can get those uploaded similar to how we've done for the other speakers so that people can access them. I'm seeing some comments in the event chat that of the slides were covered by the speaker review in the live stream. So if folks would be able to interact with them directly, that would be excellent. So folks, put your questions for Ezinne in the chat, and I will read them out as they come in. As we're waiting for questions, remember that we had an update to our CE credit opportunities. So this afternoon, if you were looking to get credit, initially for Dr. Fish's presentation before Dr. Garcia stepped in to take that slot. We are now offering both pharmacy CEUs and CHES, Certified Health Education credit, as long as you fill out your CHES evaluation PDF form. And there's instructions periodically in the event chat and on the website about how to do that. For folks who are just joining us also, the CHES evaluation form is totally separate from the event evaluation form for the summit. And for those of you who did the mini course yesterday for Asthma Educator Review, we also will have an evaluation that goes out for that. Both of the event evaluations will go out from SurveyMonkey early next week. So if you don't see anything today, don't worry about it. We still gotta get those final lists of emails of everybody who registered so that we can get the evaluation surveys out to everybody. But in the meantime, do your CHES evaluation forms if you want your CHES credit, and make sure that you're checking in on the event main page in that little box where it says check in for credits. Still watching the event chat to see if anybody has a question for Ms. Chinemere. I have to say, I love the use of imagery from that's reminiscent of Shel Silverstein's The Giving Tree, which is a book that was read to a lot of children my age. I'm 38, I was born in 1983. You know, that has some messaging that really needed an update. Yeah, so the idea that, you know, giving is a reciprocal relationship, that it's not about martyrdom, but rather about mutual benefit. I love that. It's and it's certainly very, very reflective of the philosophy of everything that we do with the Florida Asthma Coalition, which is making sure everybody's got opportunities to participate, opportunities to lead. All right, we've got some comments coming in the chat. We've got a request for that CHES evaluation form link again. So if our Altus colleagues can share that again and just keep sharing it throughout the day, that'll be terrific. We have a comment and a question. I love the presentation. How have you seen systemic racism in Baltimore specifically impact asthmatic populations?
Say it for me one more time. How have we seen systemic racism
in Baltimore, specifically impact asthmatic population? So I believe that this person is asking, you know, some specifics from your direct lived experience living and working in Baltimore with people with asthma.
Oh yeah. So like we said, systemic racism it's so embedded in our systems that when it comes to the asthmatic population here in Baltimore, it does have the ability to kind of seep into multiple things. I think one of the most common ways that we may see systemic racism is in regards to like access to healthcare, as well as transportation and the ability to move from point A to point B. In Baltimore, we don't have as many asthma specialists in regards to pulmonologists and allergists as we would like. But the ability for families to be able to transport themselves from point A to point B, like to get to doctor's appointments, is very difficult. And a lot of it is strategically placed bus stops and how families have access to be able to get to these bus stops, because many people in Baltimore don't drive. They use public transportation to get from point A to point B. But if the closest bus stop, based on zoning and all the other aspects that are, you know, based on policies and laws, if it prevents you from having a bus stop that is within 4 to 5 blocks, and you have to walk to that bus stop with 3 children in the rain, you may be less likely to go to your appointments because it's an inconvenience. Versus if you have a bus stop that's around the corner and you're able to get there quickly. And, you know, so some of these systemic factors that we don't think about, like where we place a bus stop, where do we put trains, what are the ability to have access to services outside of an emergency room, because in Baltimore, we have two main hospitals that our communities flood, especially our asthmatic patients, they flood. And a lot of that is because access to a primary care doctor may be a little further out, and the access to get there without the transportation may be more difficult, but I can walk to that hospital. I can walk to that urgent care. So things like that we don't think about are ways where systemic racism prevents our families from being able to get to the optimal health.
Absolutely. Ezinne, thank you so much. I see another question really looking toward interventions. This person is saying, congratulations on a great presentation. I might have missed it, and if so, I apologize. I was juggling home life. But could you give a couple examples of an intervention that would achieve justice? And Ezinne, if you want people to be able to see you and read your lips, please do feel free to turn your camera back on. Never want to put anybody on the spot, but if you're open to it, we definitely want to be able to see you.
Sure. Can you see my face now? I forgot my camera wasn't on. Okay, perfect. I think when it comes to interventions, to be able to address systemic racism, it's very particular to your community. There's not one size that fits all, and all of our asthma populations are different. Of course, the vast majority of us are focusing on Black and Hispanic population, low income families. But when we talk about health disparities and we talk about certain things that we see, we have to kind of take a second to be able to really dig in deeper to be able to understand the interventions, because I can see now my population of asthmatics that are in my clinic that for some reason we're having a really hard time with getting them to adhere to their medications. Like they're not using their controller inhalers, no matter how many you prescribe. But is it just the controller medication that's the issue, or is there a literacy issue? And as asthma professionals, a lot of times we will advocate for easier medication equipment to use so that our families have less difficulties using the inhalers. But I'm going to challenge you guys to think outside the box. What if, as an asthma professional, you start advocating for adequate school education, resources within the school, because literacy starts somewhere. It didn't start at 45 because I'm an asthmatic as an adult. And it doesn't, teaching my child how to use their inhaler and read the pamphlets and understand what you're telling me and being able to regurgitate it back, that doesn't start as a mom. That starts as a child. And we have to challenge ourselves in how we look at being able to solve some of these health problems, because it's not as simple as being able to just, create a program around teaching how to use inhalers. The teaching of how to use inhalers is just a fragment of what they are experiencing on their everyday life in regards to other aspects of their life. So the interventions are very individualized to what you're seeing. Anyone who wants to kind of talk more about it, I am more than happy to be able to kind of brainstorm with you and talk. But there's no one size fits all. We all have to be able to really dig deep and see what are the problems that our current patients are experiencing, and how does systemic racism or the racism they're experiencing from professionals, how is that impacting their health?
Definitely terrific. Thank you so much for sharing. And I definitely encourage folks, our speakers are happy to follow up with you. The relationships that folks build at the Asthma Coalition Summit have always been really dynamic. This is a continuing conversation. And we really look forward to maintaining those relationships over time. So this is a place to start, but I don't think this is your only chance to interact with our speakers. All right, and I see a lot of support in the chat for your answer to the last question, and also mentioning different barriers and injustices that people may face with respect to language. We were talking before about how just because you speak English doesn't mean that that's the most person-centered language for you to get your care in. And there, of course, are concepts that don't translate readily in English. even if you speak aloud and use English to communicate in everyday life. And then we also talked about, interpretation, not just in other spoken languages, but sign language, and just, the diversity of ways that we communicate in ways that it's best for us to receive that input and build that trust.
Absolutely.
When we think about conversation, that can be a lot of things. And I'm very open, I'm neurodivergent. So this is beyond my mind, not just as somebody who grew up speaking multiple languages, but also about, well, what does it mean to have a conversation that feels safe and where the messaging is really clear?
Absolutely. Absolutely.
And we're seeing a lot of comments in the chat about, persistent needs and just diverse needs to support our Spanish speakers. We will also hear more later in the day from our home visiting work group about new opportunities that we've really been able to nurture to support our Creole speaking community in Florida, especially for people who are ethnically Haitian who speak Haitian Creole. All right, let me check. So we still have a little bit of time. This is terrific. So if folks have more questions for Ezinne, please feel free to put those in the chat. And then we will get started with our speaker meet and greet hour right at 1 o'clock Eastern. So there'll be lots of choices for what breakouts people want to attend. We will have live breakouts with exhibitors during that time. So that's where you can go and visit each of our sponsors and have some actual live time to interactively ask questions. But you can also feel free to float around in that expo hall, look at the websites, look at the resources that our sponsors have provided. That'll be open all day long. And I did see for our person who requested information about the CHES form and a direct link to it, our Altus colleagues a few minutes ago did paste that link in again. So it's a big long link on the Florida Asthma Coalition website that takes you to a PDF form. All right, still seeing supportive comments in the chat. I definitely commend Dr. Jones's work as well. We've been fortunate to host her for a couple of events with FSU College of Medicine over the years as well, and with the Florida Health Equity Research Institute, and she's awesome. All right, I am going to stay, oh, okay. So, all right, speaking of languages, comment from Andrea Jensen. It also helps to use person-first language. So not using the term asthmatic, diabetic, etc. Person-first language would be, I have asthma, little Johnny has asthma, etc. So this is one situation where, and I'm curious to hear your thoughts as well, Ezinne. This is a situation where I'd recommend asking people what they prefer, because it may not always be the same depending on context. And sometimes different types of lived experiences feel right to describe with different types of language. So it's very different talking about, having cystic fibrosis versus being a neurodivergent person or an autistic person. That's identity first language. That can be important too. So let's hear from Ezinne about your recommendations about how do you make those choices about what kind of language to use.
I agree. I spent several years doing home visiting and case management, and I ask. I agree with Andrea. There is some form of acknowledging the fact that being an asthmatic isn't the only thing I am. I am more than an asthmatic. I have asthma, but I also have a life that is outside of asthma. So it gives me the opportunity to be able to identify myself the way that I want to be identified. And I think the best way is to be able to ask, and also listen. Like the best case managers, the best health educators, the best community health workers are the ones who talk less and listen more. So listen to how your families address themselves, and repeat how they address themselves. If you want to know, a lot of the times it's just how you just listening to how they address themselves, you'll be able to identify that. But I agree with Andrea. There is definitely a level of not making the disease you, that sometimes saying, Ezinne is an asthmatic rather than Ezinne has asthma. That can allow, in that sense of building trust and not making every aspect of your interaction with them about just their disease, because they're more than just the disease that they have, the chronic illness that they have. So, but I agree, allow the families to guide that process, allow the person to guide that process.
Definitely. And I would add, when somebody tells you who they are, believe them. Maya Angelou said that a long time ago, and it applies in so many different ways. Trust the people you're working with, that we know ourselves and that we know ourselves best.
Absolutely. Absolutely. One of the basic keys to building trust is allowing the family or the person to guide the process, because I may think I know what's best for you, but the only person who knows what's best for you is you.
Absolutely. And so, I had a provider tell me once, they corrected me when I spoke, because I referred to my cystic fibrosis as an authentic truth of what I'm living and how personal that journey is to me. And they corrected me. I said, oh no, it's the cystic fibrosis. That's not all you are. And I'm thinking, in the moment, I'm a person who would really like to give you a light slam or two. But hearing and paying attention and just asking that question, I mean, honestly, that alone communicates so much about caring about
Absolutely.
what's for that person. It works for health conditions, it works for pronouns, it works for just language in general, values, preferences about what your healthcare is going to look like, how you like to receive information. It's very evaluative, honestly.
Yes. I couldn't agree more. And at that moment, what you were looking for was the ability to kind of speak and be able to feel heard. And by correcting you, they took that from you. And a lot of times we don't allow our families to be in the moment of what they're experiencing, especially with our asthmatic families. I know we have somebody who's talking about home visiting later, but one of the biggest things about home visiting is sometimes you will walk in and yes, the child has been to the emergency room 3 times in the last 3 months, and they're using an inhaler, a rescue inhaler every single day, but they're going to get evicted. And they want to talk about the eviction. So what do you talk about? The eviction. And, don't strip away their power by making them speak about things that are not necessarily the most important to them right then. And don't push their feelings to the side by redirecting where you want them to go. And what that doctor did to you was literally strip the ability of you to be able to be in the moment, being present, identifying how you want to identify, and allowing that doctor to be a support system to you.
Definitely. And this is why those multiple modes of communication are so important, because there's support now for providers, making sure that the person who came to see you can still cover everything they initially thought they wanted to cover. Maybe they need to talk about the eviction in the moment, but they can follow up with you in
Absolutely.
the patient portal. They can call back, talk to a nurse, a case manager on their way out, making sure that full scope of needs is met in the way that's best for the person while providing support in the moment. I'm seeing supportive comments in the chat about just that general practice of centering what matters to the person with respect to language, identity, experience. I also have to give a shout out to our wonderful colleague, Bruce Brown, who has shared some information following up on Dr. Doherty's presentation, with some information about our own Florida representative, Krishnamurti, examining the marketing strategy used by Jewel. And then, oh my gosh, so Andrea's coming through with the share here. I was a patient stakeholder on a PCORI grant, and our entire white paper had to be written to take out the term, quote, asthmatic and replace it with child with asthma, et cetera. I did warn them to use patient first language, but they didn't listen to this public health expert. So I had to rewrite the very long white paper. Yeah, don't get in that situation. Make sure that everybody's going to be able to have a discussion early on about what type of language is going to best fulfill the group's goals in working together, and honor people's individual experiences. And I mean, healthcare is teamwork, right? Those of us who teach healthcare providers, who are healthcare providers, we know it's teamwork. It's a lot easier to work effectively as a team when we check in about what good teamwork looks like for each person, and when we intentionally create those opportunities to practice. When you get unfamiliar information or new information, it's totally okay to make that space and just let me make sure I got this right. Double check, practice it. All right. Ezinne, I want to thank you for an absolutely terrific presentation, and a wonderful question and answer session. This was just absolutely fantastic. We're looking forward to staying engaged with you.